Hello doctors. In this video I am going to share with you why an MDI plus spacer with or without a mask is the best device for children, is the recommended device for children. Now in my previous video I had enlisted all the disadvantages of using an MDI alone, and I'd also mentioned that the spacer is something that helps take care of all those disadvantages and makes it a very safe and most effective device. Now this spacer is a zero static spacer, so it is made of anti-static material. Preferably go for an anti-static material because otherwise the drug gets all attached onto the wall when we actuate the drug into the spacer. This particular spacer is called as the zero stat VT spacer. The advantage of this shape is that the shape is in the form of a plume, and the drug that comes out of the MDI is also plume shaped. So that's why lesser drug is wasted as compared to if you are using a cylindrical. The other advantage of the spacer is that it acts as a holding chamber. It keeps the drug suspended inside itself so that there is no rush of actuation inhalation coordination, and the drug can be actuated in this and inhaled at one's own pace. Because it is not going directly and hitting the oropharynx, there is lesser oropharyngeal deposition. Because there is lesser oropharyngeal deposition, there are also lesser side effects associated when we are using an MDI with spacer. Another very important aspect of using an MDI and spacer is that it can also be used in case of an emergency. There are several studies that have compared head to head the effect of a nebulizer versus effect of an MDI and spacer in case of an acute exacerbation, and an MDI and spacer has been found to be as effective as a nebulizer. In fact, for a nebulizer you have to nebulize for a longer time, there is more wastage of the dosage, more side effects, but with an MDI and spacer you get a quicker action, less wastage and lesser side effects. So it is a very good, and especially in the case of current scenario of COVID, where nebulization has been almost like banned and you are not supposed to do any aerosol generating procedures like nebulization in the clinic. This is the best device to use if the patient comes to us in an acute exacerbation of asthma, and especially if the oxygen saturation is maintained. So mild to moderate asthma, MDI and spacer is the device to use. Now, how do we use an MDI and spacer in children? First of all, how to prepare the spacer, connect the spacer. So the spacer will come in this form. There is a slot over here and there is a notch over here. So this has to be fitted in properly in this notch and has to be rotated so that the device gets locked. Now the spacer is ready for use. The MDI has to be shaken, connected. The mouth or the cap of the mouthpiece has to be opened. The device is to be given into the child's mouth. Ask the child to exhale into the device, because exhalation is what the children are more used to doing. So ask the child to exhale into the spacer and then actuate so that the next breath that the child takes is that of inhalation. I'll just demonstrate. So again, ask the child to take a slow and deep breath through the spacer and hold the breath for 10 seconds. If it's a younger child who cannot perform this kind of controlled breathing maneuver, then what we can ask the child to do is to breathe in and out of the spacer, where the first breath is out and then we actuate. Please note. We ask the child to do this for at least half a minute, at least 30 seconds, if possible up to 1 minute. Breathe in and out of the spacer. If there are children who can do controlled breathing, then we can also ask them to hold the breath, exhale out, hold the breath. This is for older children. Connect, actuate and inhale directly. I'll just show you. So older children who can do controlled breathing can be advised to do it in this particular manner. The only limitation of the spacer is that it is a bit difficult to carry, but otherwise it has got all the advantages to it. And to overcome this limitation, there is something called as a mini spacer that is also available, which may be used in case the patients don't want to use this big spacer, but advisable to use the zero start VT spacer. Now, certain important aspects about MDI and spacer that make it the best inhalation device. And I would like you to focus on this particular slide. It was a study done by Fink JP and it was published in 2000, but it holds true of course even today. Is a comparative study between the nebulizer, the MDI and spacer, MDI only and a dry powder inhaler. And please look at the graph where you will find that first of all, with the nebulizer, the drug that we are giving is in milligrams, so it is 2.5 milligrams, whereas all the other devices, the drug that is given is in micrograms. The deposition in the lungs depicted by the green color, you can see the comparative deposition. Deposition in the lung is best using an MDI and spacer and a dry powder inhaler. But the oropharyngeal deposition with the dry powder inhaler is much higher as compared to an MDI and spacer. Oropharyngeal deposition with nebulizer is very high, with MDI only is very high, with dry powder inhaler is also quite high. And of course, this is the drug that is wasted, it remains in the apparatus. So it's okay. As long as the drug deposition is good and minimal oropharyngeal deposition, that is what we want from an ideal device, and that is what we get with an MDI and spacer. So an MDI and spacer is the most effective and the safest device to be used for inhalation therapy. Now, some important aspects about MDI and spacer. Can children less than 3 years be given an MDI and spacer? They can be given, but along with a mask, because children can usually, younger children usually may not be able to breathe in and out of the device. So it's very important that we make sure that for younger children we use this additional device which is called with a mask. All that you have to do is shake, connect, fix the mask snugly. There's a notch over here for the nose, so it fits snugly over here. Actuate and just allow the child to breathe in and out through it. Okay, I'll just demonstrate. So all that the child has to do is just allow the mask to be here and breathe in and out of the mask. There's a one-way valve to the baby mask as well, where the exhalation will open up the valve and allow the air to go out. So this becomes a very useful device for children less than 3 years. Can older children also be given MDI plus spacer plus mask? Remember, for older children more than 3 years, if you add a mask, then we are just increasing the dead space. Lesser and lesser drug will be available for inhalation. That's why for older children, unless like some children who are 3.5 years or 4 years who just cannot do it with the spacer only then do we add a mask. Otherwise, all children more than 3 years should be given only the MDI and spacer without the mask. Okay. Can we actuate 2 doses in the spacer at the same time? Remember that 1 dose when we actuate, it is available in the spacer and available for inhalation. But if we actuate 2 doses at the same time, the second dose is just a waste. So we are just wasting the drug. Secondly, the valve over here, when the drug comes out of the valve also comes down to a very cold temperature. It's about minus 30 degrees C. So to allow it to come back to room temperature so that the next dose that is released is also equal in the dosage, we should allow it to come back to the room temperature. So between 2 dosages or between 2 actuations, there should be a gap of minimum 30 seconds to 1 minute. Okay, so whenever you have to give 2 dosages, for example in an acute exacerbation you are giving 2 dosages, you have to repeat all the steps: shake, connect, hold, actuate, and ask the child to inhale. So all the steps have to be repeated. Another very important question that we come across, and a clinical situation that one comes across, is can we give it when the child is crying? Well, crying is an expiratory maneuver. If you you can try it out. When the child cries, the more of the maneuver is expiratory maneuver. So when the patient is inhaling while crying, there have been studies that have studied the drug with radio-labeled inhaled medication, and it has found that when the child cries, the drug goes more in the stomach than going in the lungs. So it's better to make the child calm and quiet and only then give the inhaler. Initially, yes, of course, children will not accept it. They will be, they will try to reject it, they will cry, etc. But then just give this inhaler to the child, ask the child to play with it, make friends with the inhaler device, and show them. So do it yourself, do it on another child who is a little older. Let the child realize that it's not going to hurt, it's not going to harm, and then maybe you can give. So initially the child may cry, but later on the child will get used to it. Preferably don't give it when the child is crying. How do we clean the spacer? It is very important that we clean the spacer because there is likelihood of bacterial growth inside this. I have seen personally fungus growing inside the spacer. So it's very important that we ask the parents to bring the spacer, bring all the devices, and inspect the device ourselves. What I advise patients is every time the child has taken the inhaler, just wipe it off with a toilet tissue roll. They can keep a toilet tissue roll handy. Wipe it and just throw away that particular piece of tissue. If they use a cloth, well, they'll be using the cloth again and again, the same cloth they will be using. So better to advise to keep a toilet tissue roll. Just wipe it and throw it away. The spacer has to be washed at least once a week. It should be held under running tap water. Just rinse it under running tap water, shake it and leave it for air drying. It's best not to wipe it from inside, or it's very important that this is not boiled. You don't need to use any, if at all you have to use a detergent, a mild detergent may be used, otherwise it is not required as well. Just wash it under running tap water, rinse it and keep it for air drying. Once a week it is important to do this. Okay, but what is important is that you have to make sure that the patient is replacing the spacer every 6 months, because 6 months is the life that is accorded to the spacer. In worst case scenario, if the family is economically challenged, then maybe up to 9 months, but otherwise the spacer has to be replaced every 6 months. I would like to reiterate here that every time the patient comes to you, please make sure that they show you how they are using. There are n number of mistakes that they will make. They will not open this. The child will just keep on blowing into it, or there are children who just go. It's not going to help. So make sure that you see how the child is using it every time. Also inspect the device every time for any fungal growth or anything abnormal, and guide the parents accordingly, appropriately. Okay, so these are the key points that we should remember when using an MDI and spacer. But I would like to reiterate that MDI and spacer is the device recommended for all children. Thank you.